A 35-year-old woman who desires to conceive presents to her gynecologist for assessment of her fertility potential. She's been trying to conceive for the past year without success. Her medical history is unremarkable and she has regular menstrual cycles. Which hormone is primarily responsible for evaluating her fertility status? So she's 35-year-old, and which hormone should be measured for evaluating her fertility status in this case? Why AMH? Everybody has answered AMH. Why is it AMH? AMH gives you indication of what? It tells you about the ovarian reserve, and that is again important for a 35-year-old woman. So the answer in this case should be AMH. And this is a glycoprotein which is produced by granulosa cells in ovarian follicles. This could also serve as a question, where does it originate from, the AMH? A 52-year-old woman presents to her gynecologist with irregular menstrual cycles and other symptoms suggestive of menopause. The clinician decides to assess her menopausal status. In the evaluation of menopausal status, which hormone is commonly utilized as a biomarker to confirm cessation of ovarian function? Yes, FSH. Elevated FSH means that probably she is menopausal. And that means no estradiol or minimal estradiol is being produced in the body. In clinical setting, a group of researchers aims to investigate the molecular mechanisms underlying a rare genetic disorder affecting the gastrointestinal system. They collect tissue samples from patients diagnosed with this disorder and utilize northern blotting as part of their research methodology. What is the primary purpose of utilizing northern blotting, a molecular technique for nucleic acid analysis? So what does northern blotting do? This is for detection of RNA. Southern is for detection of DNA. Western is for proteins. So this you should remember because either of it could be a question. And what is Eastern? Eastern is an extension of Western, so it is post-translational protein modifications is what is assessed through Eastern. So either of this could come as a question. A 26-year-old woman presents with amenorrhea for 3 months. Her HCG level is 5 milli international units per ml, and her prolactin level is greater than 1500 MIU per liter. What is the likely cause for her condition? This is easy. Yes, this is a pituitary adenoma, most probably a microadenoma, most probably a prolactinoma. A 32-year-old reproductive aged woman presents with a 6 centimeter multiseptated cyst, and her CA-125 levels are within normal range. She is prescribed low molecular weight heparin therapy. In management of this patient, which monitoring method would be most appropriate for assessing the efficacy of low molecular weight therapy? So again, in this question, you can see they have given a big clinical scenario just to confuse you. The main thing what they are asking you is that how do you monitor when you give low molecular weight heparin therapy? How should you monitor? And it's an easy answer, anti-factor 10A levels. That is how you should monitor it. But they have added CA-125 levels that is presented with us is just so that you get kind of confused with the scenario. And they have a habit of doing this, so don't get confused. During a routine prenatal visit, a 30-year-old pregnant woman, Mrs. Patel, expresses concern to her obstetrician about the occasional palpitations she has been experiencing. She's currently in her second trimester of pregnancy and wants to ensure the health of her heart for the remainder of her pregnancy. Which ECG finding is typically observed as a normal adaptation to pregnancy? So increased heart rate is the most common or a typically observed normal adaptation of pregnancy. Other changes in ECG can occur, but increased heart rate is something which you should take into consideration as the most commonly occurring change in her ECG pattern. At what gestational age does hepatic induction, marking the initiation of liver development, typically occurs during embryogenesis? So what period of gestation does hepatic induction occur during embryogenesis? This is gestational week 6. Next question, a 40-year-old woman presents with postmenopausal bleeding. Pelvic examination reveals a 3 centimeter friable lesion on the cervix. Biopsy shows squamous cell cancer. Which of the following is most appropriate next step in management? So this is probably stage 1 because this is confined to the cervix. So what should you do in this case? And she's 40 years old, so most likely she has completed her family. So what should you do? You should go ahead with a total abdominal hysterectomy with a bilateral salpingo-oophorectomy. So a 32-year-old woman presents with recurrent urinary tract infections and dysuria. Urine analysis shows pyuria and bacteriuria. Which of the following is the most appropriate next step in management? Again, this is a very easy question. Recurrent UTI and her urine routine is showing pyuria and bacteriuria. What should you do? Obviously, you should do urine culture and sensitivity. A 29-year-old woman presents with recurrent vulvovaginal itching and burning. On examination, white curd-like vaginal discharge and erythematous vulval plaques. Which of the following is most likely diagnosis? Again, I need not tell you this, and all of you know the answer to this. This is obviously candidiasis. What antibiotics should be administered to prevent early onset GBS disease in women who has consented to intrapartum antibiotic prophylaxis but are allergic to benzyl penicillin? Again, GBS infection, make sure you read the GTG guidelines pertaining to GBS. Very, very important from perspective of MRCOG exam because GBS is the most common cause of mortality amongst the newborn babies in the UK. So GBS prophylaxis is mainly through benzyl penicillin. And in case the woman is sensitive to or allergic to benzyl penicillin, in that case, what should you give? You should give her clindamycin. And what is the dose of clindamycin which you should give her? You should give her 9 milligram IV every 8 hours. Again, this is something which is very important. A 34-year-old woman presents to the gynecology clinic with a history of infertility for the past 2 years. She describes a previous ectopic pregnancy that was managed surgically. Upon further inquiry, she reports a history of recurrent pelvic inflammatory disease during her late teens and early 20s, which was associated with unprotected sexual activity. On examination, tenderness is noted upon palpitation of her adnexal region. Pelvic ultrasound reveals bilateral tubal occlusion with the evidence of hydrosalpinx. Based on her clinical history and findings, what is the single largest cause of the acquired tubal pathology in this patient? So what is most likely she's suffering from? She's suffering from PID, and probably also she had an ectopic pregnancy and PID has affected her tubes and it has resulted in hydrosalpinx. And what is the most common cause of PID or hydrosalpinx? It is obviously chlamydial infection. So that is again something which is very, very common in the UK. A 29-year-old Caucasian woman visited her general practitioner at 37 weeks into her pregnancy after developing chickenpox rash during the winter season. She was prescribed oral acyclovir for a week and advised to return if her condition worsened. However, 3 days later, she presented to the emergency department experiencing severe shortness of breath. What is the likely diagnosis for her condition? What's the likely answer? This is a varicella zoster pneumonia. And this is the reason why varicella infection during pregnancy is particularly dangerous, because this can exaggerate and it can exacerbate and it can worsen and cause pneumonia. And varicella zoster pneumonia is a common complication of varicella zoster infection during pregnancy. And that is why if a woman is exposed to a child with chickenpox rash, it becomes slightly important to manage that patient. At 28 weeks of gestation, a 32-year-old multiparous pregnant woman visits the antenatal clinic, disclosing her 4-year-old daughter's recent bout with chickenpox. Uncertain of her chickenpox history, her serology results indicate negative for varicella zoster virus IgM, positive for varicella zoster IgG. So she is negative for IgM and she is positive for IgG. So what does this indicate? If it is IgM, that means she was recently exposed and there are antibodies, because IgM is the first antibody which appears. And this is later replaced by IgG. So if there is presence of IgG, what does this indicate? That she had a previous exposure, which is not recent, because if it would have been a recent exposure, she would have had IgM antibodies. So she had an exposure sometime in the past, which has now resulted in formation of IgG antibodies. A 32-year-old pregnant woman, pregnant for the first time and working as a school teacher, presents at 16 weeks of gestation with a maculopapular rash and symptoms resembling a cold. Serology results: rubella IgG positive, rubella IgM negative, parvovirus B19 IgG negative, parvovirus B19 IgM positive. So what is the probable diagnosis? So what, now in this case, IgM is positive for parvovirus. So that means what did she have? She had a recent infection with parvovirus B19, right? This is quite clear in this case. So which statement describes the double Bohr's effect? We discussed about Bohr's effect previously in the discussion also. I'll tell you again about Bohr's effect and then we'll talk about what is double Bohr's effect. Bohr's effect basically means affinity of hemoglobin to combine with oxygen. This is inversely proportional to two things, to carbon dioxide levels and to the levels of H plus ions. So if carbon dioxide levels increase, that means the affinity of hemoglobin to combine with oxygen, it reduces. So this facilitates transfer of oxygen into those tissues. Similarly, if hydrogen ions, they increase, that means pH reduces. So if pH reduces, again, the affinity of hemoglobin to combine with oxygen, it reduces, and this facilitates the release of oxygen to the tissue. So double Bohr's effect means both these conditions are there. There is increased CO2 levels and there is reduced pH. And this will reduce the affinity of hemoglobin to combine with oxygen. And as a result, oxygen will be transferred. And if there is something else like carbon dioxide or metabolites, this will be released. Oxygen will be transferred to the tissues, and carbon dioxide and hydrogen ions or other metabolites will be released away from the tissues. So if we now come to the question, what do you think is the answer? The fetal side becomes acidic, no. Metabolites are transferred from the fetus to the mother. Yes, oxygen is transferred from the mother to the fetus, and the metabolites such as carbon dioxide and hydrogen ions and other products of metabolism are transferred from the fetus back to the mother. Maternal and fetal oxygen dissociation curves converge, they don't converge. The maternal oxygen dissociation curve shifts to the left. If the oxygen dissociation curve shifts to the left, what happens? It results in higher affinity of hemoglobin to oxygen, and therefore oxygen is not released. So this is also not correct in this case. Maternal side experiences an elevated pH. No, this is also not correct. So the option is basically B, that metabolites are transferred from the fetus to the mother and oxygen is transferred from the mother back to the fetus. Bohr's effect, double Bohr's effect, the effect of various things on the oxygen dissociation curve, again, very, very important. So I think that, no, there's another question. So I think this is the last question. So a 33-year-old woman with HIV, not yet on antiretroviral therapy, visits a genitourinary clinic. She reports deep dyspareunia, bilateral pelvic pain, and increased vaginal discharge, but is otherwise healthy and has no fever. Serum inflammatory markers are within normal range. She receives treatment for suspected pelvic inflammatory disease. What is the best course of treatment? So in a HIV positive patient, what is the best course of treatment for PID? Because of HIV, the disease symptoms might be severe, but the treatment strategy remains the same. So it is standard 2 weeks of antibiotic treatment in an HIV patient also for PID. It's just that the symptoms may be more severe, but they will respond well to antibiotic treatment. So that was all for this session. Thank you so much for listening to me and for being here.